things you expect to see if you're in your practice or, well, hopefully, I mean, I know everyone has a different perspective. This is a lot of the participants online today are from all over the world, but also be interesting to see what you all see. And if you have something similar that's specific to your area, feel free to share. Okay, we'll go ahead and get started. All right, so the first case is a lateral X-ray. Does anybody want to describe this? All right. And then there's also a chat as well. Okay, so I'm going to go ahead and, sorry, say that again. Okay, I'm going to go ahead and start with this one. So this is a lateral X-ray, and you can see that the cardiomediastinal silhouette is enlarged. Usually there's fat between the sternum and the... one second, I think okay. Can you hear me okay? All right, cool. So you can see that there is the cardiomediastinal silhouette is enlarged, and then there's some soft tissue attenuation between that of the sternum and the heart. And so this is what you might see with a pericardial effusion, a large one. And you can see that if you look closely, there's a dark line where there's epicardial fat, and then a little bit of a dark line around it. So we often refer to this as the Oreo cookie sign, because the dark areas resemble the chocolate on the outer side of the cookie, and the inside is the filling. But this is a good example of a large pericardial effusion that you see on a lateral chest X-ray. All right, so this is the second case. Does anybody want to take this one? Okay. So this is a patient who has a CT image. Here you have an axial image and a coronal, and they have a pleural effusion here on the right side. And the area of abnormality that I want you all to look at is this area, this round opacity. So you'll notice that both here and then also on the coronal, it looks like it's located up against and near the pleural effusion and the pleura. And so the reason I present this case is because it's a good way to, well, for us, for our residents, it trips them up because they think it could be a mass for some sort of pneumonia or infection. But some of the classic features here is that it has this round opacity next to a pleural fusion and pleural thickening. And then it has this, what we call like a comet tail or bronchovascular crowding at the tail end of this opacity. So this is a good example of round atelectasis. And so how does this happen? So usually you'll have a pleural fusion, probably a chronic one with inflammation causing pleural thickening, and it attacks onto the lung parenchyma and wraps it and forms this round atelectasis. So this is a good one, just not to make sure that you confuse it with a mass. It's benign. You don't do anything with it. Just know that with a pleural fusion, pleural thickening, and a rounded opacity with bronchovascular crowding tailing it, this is an example of round atelectasis. Any questions on that one? All right. So we'll go ahead and move on to the next case. Anyone want to describe the findings here? Any volunteers at all? Okay. I see we have some more people joining as well. All right, so here we have a couple axial images of the chest. It looks like it's kind of in the mid chest and the right middle lobe, lingula, and you can see the lower lobes here. I have an arrow on the abnormality here, you'll notice that there's some bronchial thickening, as well as these nodules. Now, these nodules are within the center of the secondary pulmonary lobule, so I'd call these central lobular nodules, as opposed to paralymphatic nodules or randomly distributed nodules, because each of these nodule distributions have a differential. And so, but the most common would be a central lobular nodule, as you see in this case. And if you look down in the lower lobe here, you'll notice that they have these central lobular nodules are branching out. So this is an example of a tree and bud nodule pattern. And all this means is that there's inflammation at the level of the airway, in this case, at the center of the secondary pulmonary lobules and the more branching, smaller airways. So it could be from an infection, it could be from some sort of inflammatory, non-infectious cause. But when we have a patient, and if I had said this was a 70-year-old female, an older patient with more of these abnormalities in the mid lungs, especially anteriorly in the right middle lobe and the lingula, and say if there was bronchiectasis involved with it, then I'd be thinking it'd be a chronic airway inflammatory process from an infection, usually described as MAI or MAC infections. So this classic radiology sign of a 70-year-old female with this tree and bud nodular pattern with bronchiectasis, we refer to it as the Lady Windermere sign, because older females tend to have more predisposition to developing this. And what happens is they may not necessarily need treatment, but over time can cause destruction of the lungs as they get more bronchiectasis and worsening infection. So the pulmonologist might go in and bronch them and verify if this is indeed MAI MAC infection or not before they start the treatment, which is usually a 9-month antibiotic process that has a lot of side effects. So you want to make sure that you have the diagnosis before you start the treatment. If it's not causing much issues, the patient's older, they may opt to not have the treatment in that case. Obviously not, it depends from patient to patient on how bad the disease process is, and then how much lung destruction it's causing. All right, any questions on that one? Okay. Next case is this. So this is pretty unique. So we have an X-ray coned in on the mid to upper lobes. You'll notice that abnormality is up here. It looks like I would describe it as cloud-like hyperdense opacities. And so there's hyperdense opacities in the upper lobes, kind of cloud-like. So, some things I would think of would be, is it an infection? Is there some sort of inhalational process happening here? But the hyperdense appearance of it is interesting and is unique because it's probably calcified. It's somewhere attenuation of the adjacent bone. So does anybody have any ideas of what this could be? All right, I'll give you a multiple choice. So one could be an infection. Two, it could be a vasculitis. Three, metastatic calcifications. Four, dendriform ossification. Any guesses? Well, if you're thinking of metastatic calcifications, you would be correct. This happens. So the situation in which you might see this would be a patient with renal failure. And so they have a normal lung environment, but they have renal failure that causes calcific deposits throughout the body, as opposed to having a lung abnormality and the calcifications happening as a result. That would be a case of dendriform ossifications, as opposed to metastatic calcifications. Now, when you look at the appearance, the difference is that with metastatic calcifications, they tend to be more upper lobe, more cloud-like calcifications that develop. And they don't also always have to be calcified. They might have some mild calcifications and look hyperdense or not calcified at all. But they will be in the presence of a patient with end-stage renal disease, as opposed to dendriform ossifications, which is essentially just calcifications along areas of fibrosis. And so maybe you might more likely see it in the lower lobes peripherally. And so since it's calcification of fibrosis, the lung is abnormal, and you usually, or I usually will see it as reticulations that are calcified. So dendriform means tree-like, and then you can imagine what that could look like, these little branching reticulations that are calcified, as opposed to this, which is more cloud-like calcifications in the upper lobes. So this is a benign, despite the name, it's a benign, and it just happens with patients who have end-stage renal disease. So metastatic calcifications. All right, any questions on that one? All right, we're going to move on to the next case. All right, so this is a CT image. Anyone have any thoughts of what this could be? Feel free to put it in the chat box, or you can, if you want, you can unmute and describe it. All right. So this is an example of, so let's start with the description here. So the way I would describe it is that you have diffuse ground glass central lobular nodularity. You can see it's very extensive and sort of uniform. And you can see that there's good intervals between each central lobular ground glass opacity. There's some subpleural sparing as well. So you can see I can pretty much draw this dark line around these opacities. And because of that, since it's sparing the periphery and you have good intervals between each one, this is in a central lobular distribution. And it's very, I guess it's sort of like coming out like a cotton ball. So maybe it looks like diffuse cotton ball type ground glass central lobular opacities. So pretty extensive. So things that can cause that could be an infection. It's pretty diffuse. So in this case, I'd also be thinking of an entity called hypersensitivity pneumonitis. And maybe I'm sure you all probably have this in other places, but in the U.S., it's something we see quite frequently, especially in our division, since we get a lot of referrals all throughout the Southeast. But hypersensitivity pneumonitis, the pathology is that you have some sort of antigen, environmental antigen, that's inhaled and causes a reaction, an immune response by the body. So it tends to be more mid to upper lobe, and it can have different imaging appearances. So this is one type of appearance of hypersensitivity pneumonitis. The other more common and popular one that is described in the radiology literature is the three density sign. So in that situation, you have ground glass opacities, and that's usually more of it takes up the entire secondary pulmonary lobule from all the inflammation, next to areas that are normal, and then next to other areas with air trapping, so they're very dark. So the three densities is the really dark areas from the air trapping, normal lung, and then abnormal inflamed lung. So that's a very common sign, and air trapping is a unique hallmark sign that might suggest hypersensitivity pneumonitis. Now, in both descriptions, they can lead to fibrosis, and so you might see some patchy fibrotic changes, maybe some honeycombing as well. And clinically, so what they'll do is they'll discuss with the patient and go through a huge list of potential causes of hypersensitivity pneumonitis, all mostly environmental. And half the time they might actually find something, half the time they don't. But on the imaging appearance, it has some unique features, as in this case, or the three density sign, and the air trapping, that's very unique and specific for hypersensitivity pneumonitis. All right, next case. All right, so here's a radiograph. So whenever I'm looking at radiographs, it's good to have a pattern in which you're evaluating the radiograph. What I do is I look at the lungs both equally, and then I take one at a time. So the right lung and then the left lung. And then I look at the mediastinal structures. So the heart, the aorta, and then lastly, I look at below the diaphragm and then the bones themselves and the soft tissues. So if I were looking at this and right off the bat, if I'm looking at the both lungs at the same time, I'd notice that the right lung is either hyperlucent compared to the left, or the left is more opaque compared to the right. So you can see the differences here. And then there's also some lucency along the aortic knob right here. And I'll put some arrows on that and highlight that because that's the finding. Does anybody know what that is?
The Lobster sign.
Good. Yes. Luftsignal sign. So air crescent in German. And that signifies what?
Upper lobe collapse, left upper lobe collapse.
Great. Yeah. Excellent. So this is a hallmark sign in radiology. In this case, there was a obstructive mass in the left upper lobe that caused the collapse. And so when we go back to the radiology findings, you'll notice this hyperlucency is from the hyperexpansion of that left lower lobe going around the aorta. And you'll notice here, it's going to be some of this air. If I had another image, you can see it tracking up towards that area along the distal aortic arch and the aortic knob area that causes that hyperlucency or air crescent radiographically. Good. Excellent. Okay, next case. So we have another radiograph. Is the abnormality on the left or the right? So it's on the left, right? So compare the right and the left. There's opacities on the left upper lobe and mid left lung. If you look really closely, you can probably see these little dots here. So all of these are also abnormal opacities. And if you look very closely, you might be able to see that there's a cavitation here in the left upper lobe. And the lateral is helpful because you can see that a lot of these opacities, while they come down here, they're more confined to that left upper lobe. And you can see the major fissure here. So anybody have any thoughts as to what this could be? A cavitation in the left upper lobe with opacities everywhere in that left upper lobe and a little bit in the left lower.
Pulmonary TB.
Pulmonary TB. All right, good. Yes, and that's what that is. And so here's some axial images. So this is what we're seeing. So you're seeing this cavitation in the left upper lobe, followed by all those little dots are endobronchial spread of the TB. So you can see all of these little central lobular nodules that are branching, and then some consolidation here in the lingula. So here's the correlation here, the cavitation here in the left upper lobe lesion.
Mungkin bisa dievaluasi.
Sorry, say it again. I missed what you said.
Saga, may I interrupt a little bit?
Sure.
So
Yeah.
nothing wrong with what you said a moment ago, but the internet is cutting, is breaking. So that's why we don't hear you. It's not right or wrong. Please speak up. Sometimes we have a connection problem. So nothing
Oh.
right or wrong here. So it's breaking. I hear the internet is breaking. So different part of the world, the speed is different.
Oh, okay.
Okay, so we have to just be patient. Okay, I'm going to shut up now.
Okay. Yeah, so in the chat, someone said pulmonary TB, and that's correct. So the classic findings that we see on the imaging is that usually there's a cavitary lesion with endobronchial spread of opacities, usually like a post-primary type of TB. Maybe they had TB in the past and then it came back and reactivated. Now, there's different types of what we see of TB, and a lot of it has to do with immune status. So I'll go through some of those. So here's an X-ray. It looks pretty clear, right? So not a whole lot happening in the lungs. The main findings we have is this calcification right here, this calcified nodule of granuloma. And then there's ipsilateral, or on that same side, calcifications along the hilum and then the right paratracheal area. So this is an example of prior TB that's healed. We refer to this as the Ranke's complex. You can see here, with some arrows, some calcification there and there. So healed TB. And then this was actually the same patient. So they actually had HIV/AIDS, and then they came back and developed all these nodules everywhere. So these nodules, you can see some of them are touching the pleura, some of them are scattered. It's hard to tell, but some of them were touching the fissures as well as sort of being everywhere, and they were small. And then there's some consolidation and ground glass opacities on the left side. So this is an example of a patient who had reactivation TB in the form of biliary TB. And then incidentally, they did have this floating thrombus in the aorta as well. They didn't do well, but a good example of Ranke's complex, and then it came back and became a biliary pattern of TB. All right. So the next case, anyone want to try this one? We could walk through it together. All right, so I'm going to go ahead and get started on this one, and if you want to chime in through the chat, or if you want to speak, go ahead. I'm going to go ahead and get started on this one. So we have a radiograph. There's an opacity or a mass in that left upper lobe, and here's the CT. So you'll notice that besides just being a mass, it has this AR crescent to it. There's not a whole lot going around outside of it. Maybe just some scarring around that mass. So this ended up being a fungal ball, so an aspergilloma within a cavitation. So this was the initial scan. And if we were to prone the patient or put them on their side, this would probably move around a little bit because it's just a fungal ball. As opposed to invasive aspergillosis, which would have more ground glass around it, or semi-invasive, which would still probably have a thickened wall to it, but could have an air crescent sign as it sloughs off and becomes necrotic, sloughs off the wall and forms this air crescent. In this case, it's just a fungal ball with a normal cavitation around it, cavitary wall. It just happens to take up most of that space. It almost looks like an air crescent that you might see more with like a semi-invasive aspergillosis. But then on follow-up, they develop this. So it looks different now. You lose that air pocket in the cavitation, and it looks hyperdense. And then around it, you can see some ground glass, and it's gotten bigger. So, and then in the lower lobes, there's all these opacities. You can see some aspiration. The airways are there's stuff in the airways, and then there's some dependent opacity. So they're aspirating something. And so here's the before and after. So we have the fungus ball in the cavitation, and then it developed into this. So two things could happen. One is that it became an invasive aspergillosis. And the other thing, which is what happened here, was that it bled. So usually a fungal ball happens, or just aspergillus, we'll back up and say just aspergillus infections kind of present in different immune states. So in the immunocompetent patient, you might have a fungal ball. And then once it becomes immunocompromised, it might develop into an invasive aspergillosis. You also have, in the hyperimmune state, allergic bronchopulmonary aspergillosis that looks a little bit different. But in this case, the question is, was it invasive aspergillosis or is it bleeding? So sometimes the fungal ball can actually erode into the epithelium of the cavitation or can burrow through the bronchial artery and cause a bleed. So that's what happened here, and they had to embolize the patient. And it's a risk that you might have even with a patient who's immunocompetent with a fungal ball in a cavitation. Any questions on that one? All right, we'll move on to the next case. Case 9. Okay, so we usually at Emory, we have some very sick patients. And so a lot of times we get x-rays on the same patient multiple times throughout the day for various reasons. But sometimes we have some very complex patients who have a lot of lines and tubes. So a lot of times we're just trying to see where those lines and tubes are. And so here's an x-ray of a bunch of lines and tubes. So we have an endotracheal tube here, NG tube coming down, so nasogastric tube going into the stomach, some bilateral chest tubes with some overlying leads, and then this central line, this left subclavian central line that's coming in. And so the issue here is this central line is not in the right spot, right? So if we're putting a central line in, we want venous access, and so it should end up on the right side down the SVC near this cavo-atrial junction near the heart. But instead of coming across midline, it's coming down overlying the aorta. So there's a few things that the tip of the central line could be in. So some things to think of are, anybody have any thoughts as to where this line could be?
Left-sided SVC.
Yeah, so it could be a left-sided SVC. Could be the aorta. What else? So some other things that could be a superior intercostal vein, which comes around this area and sort of drapes over the aortic knob. Other things would be a partial anomalous pulmonary venous return. So a pulmonary vein that comes up, instead of going into the left atrium, it drains up into the left brachiocephalic vein. And then the other option, of course, is that it's not in any vessel. It's in the pleural space or in the mediastinum. So a few things to look at. Of course, if you had prior imaging, you can rule out if they have a partial anomalous pulmonary venous return or if they have a prominent superior intercostal vein or a left SVC. But if without the imaging, you can kind of also help narrow the differential depending on where the tip is. If it's coming down along the aorta, obviously, you'd be wondering it could be arterial. In that case, you'd be getting arterial blood back when you're drawing back on the line. Or if it's close to the aorta, it could be in the intercostal vein or a left SVC. If it's coming out into the lung, which this is kind of on the borderline, but sometimes I've seen actually at a recent case where it came out overlying the lung itself, then it would unlikely be in the aorta. It would unlikely be in a left SVC. So the only two things I'd be thinking of would be, is there a partial anomalous pulmonary venous return that comes out into the lung, or is it in the pleural space itself? So here's the CT images. It's a MIP, just to show you where the line is traveling. It looks like it's going into the pleural space. And they injected some contrast, and you can see the contrast dumping into the pleural space to confirm the location. So they were actually, I think they were embolizing, or IR was doing something in the abdomen. They saw where the line was placed, and so they injected some contrast to confirm that it was in the pleural space and not to be used. So you can see the contrast here on these images, and then the original location of the line overlying and correlating with these pleural images. So what do you do in this situation? Well, one thing you can think of is first you need to confirm, did it actually go in the vessel at some point and come out? In that case, when you remove it, you want to hold pressure. When you pull it out, you also want to make sure there's no pneumothorax after. So usually we'll have vascular surgery weigh in depending on if the vessel is involved or not, as we extract or remove the line. Any questions on that one? Okay, next case. Anyone want to describe what's happening here?
Peripheral cavitating opacities in both lungs.
Yeah, good. Excellent. Yeah, so there's all these opacities in both lungs. So it could be a lot of things. I'll give you the CT images. So we have a couple axial images through the chest. You'll notice that these are the opacities that you're seeing on the X-ray. And if you're looking at the distribution, would you say they're more peripheral or central?
Peripheral.
Peripheral. And is there anything unique about these opacities?
Some are cavitating.
Yeah, some are cavitating. So do you know what the diagnosis is?
Septic pulmonary embolism.
Yep, exactly. Great. Good job. So the key findings here are the peripheral distribution and the cavitations. So anytime we see this, we're almost certain that it's septic emboli. And we do see a lot of that in especially at Grady, our big safety net hospital in the city. We have a lot of drug use, unfortunately, in Atlanta and the US. So we'll see this from time to time. I'm curious to know if some of you all see it at your local practices in your country.
Not commonly.
Not commonly. Okay. All right, great. Thanks for participating. All right, we'll move on to the next case. This one's very interesting. So I'm starting with the brain MRI. And you'll notice that there's some enhancement here, some leptomeningeal enhancement. And here's another axial image with contrast. You can see some enhancement along the basal cisterns. It's pretty thick and nodular. So anyone have a differential or possibilities as to what could be causing this? So someone said Mets. Sorry, go ahead.
Sarcoidosis.
Okay.
Sarcoidosis or
Sarcoidosis, that's good. So
IgG4, yeah.
IgG4, okay, great. That's a great differential, or some sort of infection. All right, so they got a CT, and you'll notice that they have some lymphadenopathy, right? So it's bilateral, involves the paratracheal area and the hilum. And then we have some axial images on lung window, and you'll notice some nodules here. It's very subtle, but there's a few nodules right here where my arrow is. And then there's some also right here, and I'll blow that up. So here's the key finding. So we have brain findings of a leptomeningeal enhancement, and then we have lymphadenopathy with some nodules along the fissure. So what do people think? Do they feel that this has narrowed their differential to a specific diagnosis?
Yes, it does.
All right.
Sarcoidosis.
Sarcoidosis, great. Yeah, exactly. So they came in with neurological symptoms. They got the brain MRI, a CT, and then a brain MRI. And it showed this. So from a neuroradiologist perspective, that would be the differential that you guys put together. But with the chest CT findings, with the bilateral lymphadenopathy and then the nodule specifically along the fissure, which would suggest a paralymphatic nodular pattern, all the other findings or potential findings on the, or diagnoses, sorry, on the differential really narrows to just sarcoidosis as the most likely cause. So sarcoidosis in the lungs will look like lymphadenopathy, plus or minus hilar mediastinal lymphadenopathy, and then with or without lung findings, which could be paralymphatic nodules, usually along the bronchovascular distribution, and they tend to be located more centrally in the mid to upper lobes. And so when I'm looking for that pattern, I'm looking at the fissures. Is there also nodules along the fissures, along the interlobulary septa, where the lymphatics usually are, to make sure that this is indeed a paralymphatic nodule pattern, as opposed to something like central lobular nodules, which we talked about on some of the other cases. So when we're thinking of just paralymphatic nodules, the differential then narrows to, is it sarcoid, which is probably the most common that we see, rare things like silicosis, borreliosis, or some of those occupational related lung diseases. Or if it's more mass-like, it could be something like a lymphoma or Kaposi sarcoma if they have HIV/AIDS. So it really narrows that differential. But when you have these small nodules along the fissure, sarcoid or some sort of silicosis is most likely on the differential, and sarcoid being the more common. So I think combining these two findings, you can really narrow that differential and come up with a specific diagnosis that you all came up with. All right, good. Any questions on that one? All right, we'll go to the next case. Okay, this one's unique. Anyone want to describe the findings?
Perihilar opacities.
Mm-hmm.
Subacute ground glass.
Okay, and what are things that can cause that? It's a very non-specific finding, but what are things that you would think of when you come across something like this?
Pulmonary edema. Alveolar edema.
Mm-hmm. All right. Other things would be like an infection. Maybe they have alveolar damage or like an ARDS pattern. Maybe vasculitis, though much more rare. So these are all things that could potentially be causing this. And here's a coronal image. You can see the ground glass is pretty diffuse, but you can see it's more central with sparing of the periphery of the lung. So here's some images of the abdomen, specifically the soft tissues. You'll notice there's a lot of soft tissue stranding in air. So this patient had a specific type of surgery. Here's the area you can see on the lung windows. It's called a Brazilian butt lift surgery. And what they do is they take the fat and then they inject it into the gluteal region. It's a plastic surgery for, aesthetics or, for improvement, I guess, of their image based on what they think looks good. But the problem is when you take fat and you inject it in the gluteal region, it could come up into the veins and cause fat emboli. And so this is an example of fat embolism. Not something we see very often, and it's something that I think that a lot of people overlook. But what happens is you don't actually see fat in the pulmonary arteries usually. What happens is you see there's microscopic fat particles that get embolized and cause a chemical reaction that looks more like alveolar damage or a lung injury, to be more broad, that forms this more ground glass look. So we're really looking for more ground glass opacities when we're thinking of fat embolism. So this is a really good example. Something that probably don't see in other parts of the world, but I think this patient had this surgery done in Miami. It's kind of been a little bit more common in the last 10, 15 years, and we will see this as a common side effect from this surgery, unfortunately. And then just a more common companion case that we might see is you see another patient with ground glass. This has more of like a nodular look, and fat emboli can have both more of a confluent ground glass look, as it affects more of the secondary pulmonary lobules, or more nodular ground glass look that can also look somewhat confluent. But the distribution is the same, that more central distribution of ground glass opacities. So this patient had the more common long bone fracture. So post-trauma, we have a lot of trauma come into our Grady Hospital. And so after a few days from this long bone fracture, they developed shortness of breath. They got a PE study, and then we found this, which was concerning for fat emboli. So something to keep in mind. It's not uncommon, but I think it's something that people easily will look over, especially in trauma patients. All right. The next case I have, very unique. Anyone know what this is? So it's very bizarre looking to start off with. If I looked at it, I would say this is kind of a similar distribution actually compared to the fat emboli case. So we have more like central consolidation and ground glass. But uniquely, there's a lot of this really destructive cystic looking appearance within it. This is probably a very profound look of this disease process. We don't really see this much cystic changes, but this is a type of infection that you see in HIV/AIDS patients. Anybody know what this could be?
The most common
PCP?
non-human.
PCP.
Yes, great. Yes, PCP. So usually, you know, if you have a patient who has HIV/AIDS, they'll have this central ground glass look with a few cysts here and there. This is just a very profound appearance. So I thought it's like you don't see this with anything else. And maybe you all do have seen something that's similar looking where you're from, but in the US, usually if it's HIV/AIDS patients and they have this with the cystic changes, you always think of PCP as the diagnosis. All right. Any questions on that one? All right. Next case. This is a good one for, I often show my residents because especially when you're on call, you're looking at all these different findings, but people often overlook the heart. So I would say most people would agree that the heart is very important. But since we're not getting a dedicated cardiac image, like a gated CT of the heart or cardiac MRI, we often don't look at the heart. So this is a good way to think about when you're looking at CT images, always take a look at the heart. So in this situation, you see this large pleural effusion. They have anasarca, all this edema in the soft tissues. And if you look at the heart, it looks a little big. And then there's also this low attenuation along the subendocardium of the left ventricle. So right there. So the next thing is this real or not? Well, it appears that they probably have heart failure. So it wouldn't be unusual to think maybe they have ischemic cardiomyopathy that's resulted in the heart failure. And so here's a short axis view, and you can really see that low attenuation along the subendocardium. And this is in the territory of the LAD. So it's in a coronary artery distribution as well. So we got a cardiac MRI to confirm. And you can see that this area is not perfusing. And then after, usually with cardiac MRI, we give them, it's a pretty extensive and complex exam to do. And so, but we do a few of them every day, and it's becoming more common in our practice to do them. But in this, usually the way we do it, we'll get a bunch of images, look at it as a movie clip, a cine, and then we give contrast. And then after about 10 minutes, we'll get delayed sequences to look to see if there's any enhancement. And so since we're waiting so long, the concept is that the gadolinium, which is an extracellular agent, would sort of be held up in tissue that's been dead that has increased extracellular space. And so that causes too much shortening and enhancement to happen. And so basically, to simplify it all, we give contrast, we wait about 10 minutes, and anything that's enhancing is abnormal. And that's what we're looking at. And so certain enhancement patterns might suggest, is it ischemic, or is there some sort of infiltrative cardiomyopathy or other thing that's causing the issue? So based on the CT, it looked like it was vascular. It was an LAD distribution. We can see it here. That confirms that there's enhancement here. So this is all enhancing. And then in the middle, this distracting low density area or low intensity area is what we call microvascular obstruction. So it's so infarcted that it can't even reperfuse that area. And so this is suggestive of usually a very poor prognosis. They have a profound LAD territory infarct with microvascular obstruction, and it looks like it's causing heart failure as well. So just remember, always look at the heart whenever you have, especially if you have contrast and any sort of CT that you're looking at. So you might come up with some very interesting and important findings for the patient. Any questions on that one? All right, moving on to the next case. I think we have a couple more. So we do have, like I said, we do have a lot of trauma at Grady. So this case is a good example of some trauma, some not trauma, but something to look at. So this is an example of a patient who had trauma and they had a repair. And you'll notice that this is the stomach, this is the pleural space, and then there's contrast here in the pleural space. So, and then here you can see that the contrast from the stomach is spilling into the pleural space. And here's an example on a sagittal view of that connection right here. So they had a trauma. It looks like they might have had some sort of rupture or something to the stomach. And then on follow-up imaging, it looks like that has fistulized with the pleural space here, as you can see by the contrast now spilling into the pleural space. So the key thing here, the key takeaway is that whenever I look at trauma scans, I always look at the diaphragm to see, especially after like a ballistic injury or a car accident, did it cause some sort of violation to the diaphragm? Is there any sort of fistula or herniation of bowel content or anything in the abdomen going up into the pleural space? Because that may not always declare itself on the initial scan. Kind of changing gears a little bit, we'll kind of get back to that concept. We have this case. So this is a companion case. We see this large pericardial effusion and there's enhancement along the pericardium. And it looks complex, it looks loculated, is how I would describe it. You can see there's more fluid on the right side than the left, and some of it kind of has this very round, convex look. So I'm thinking that this is probably inflamed from something that's making it look so complex. So here we have images into the upper abdomen. You can see some fluid collection here at the level of the diaphragm, and then also next to the pancreas. So this patient had chronic pancreatitis, or they had pancreatitis in the past, I think a few episodes. They developed pseudocysts. So those pseudocysts had proteinaceous enzymes, and it looks like it went through the diaphragm and fistulized with the pericardial space. And you can see that connection right here, close to the bare area of the liver. So it's pretty interesting. So really just kind of putting a couple concepts together. One is that pancreatitis patients can develop pseudocysts that need to be drained, and pericardial effusions can be caused by a lot of things. Usually you're thinking of some sort of viral illness that's causing pericarditis, if it looks pretty complex, or more commonly just more of like a just increased fluid from heart failure and other things in the pericardial space, or is it some autoimmune thing like lupus causing a pericardial effusion? But looking at this one is unique because it tracks down into the abdomen, into that pericardial cyst. And so the diaphragm, while it's a barrier between the lung and the abdomen, there's also a lot of holes in it. It's just essentially a mesh of muscle tissue that contracts. And so fluid can go past above and below that space. So always keep that in mind. And so another companion case, this is another trauma case. And to be honest, I missed this case. It's always good to learn from your misses, which is why I'm presenting it here. So this is the initial trauma scan. It looks okay, and I'll come back to it because it doesn't, in hindsight, there is an abnormality here. So this was a few days later. You can see that some bowel content is actually herniating up into above the diaphragm here. And here's the actual diaphragmatic slip right there. So it's coming around and herniating up. And then a few more days later, you can see it's getting worse. And now it's pushing that diaphragmatic layer here medially. So you can see it's all starting to escape. And now most of the left hemithorax is full of mesenteric fat and bowel. So when you look back, the actual abnormality was this diaphragm. And then it continued to, so basically from the trauma, you have a defect. So it basically pulled off where it inserts. And then you start having herniation of bowel and abdominal content beyond that wall up into the diaphragm, but it occurred over multiple CT scans. So now if I see a trauma case, I always look at the sagittal view to see, is the diaphragm intact? Am I missing anything? Is there any sort of defect that I might be overlooking? Any questions on that one? All right, next case. All right, so this is an axial image, CT. So you can see that there's this opacity in the right lower lobe, some consolidation. You can see air bronchograms there. And the periphery of the lung, you can actually see some cystic changes, some reticulations. You can see it really well right here. So this is an example of cystic bronchiectasis and reticulations with subpleural sparing. So anytime we see some more lower lobe fibrosis with subpleural sparing, we think of it being secondary to nonspecific interstitial pneumonia or NSIP, as opposed to UIP, which affects the subpleural space of the lungs. And more specifically, when we're thinking of that pattern of NSIP, we're thinking, could it be from a connective tissue disorder causing that? And this is probably some sort of mixed connective tissue disorder, scleroderma. You can see the esophagus is also dilated. So they have some sort of esophageal dysmotility happening related to all of this lung fibrosis. So the important concept is that they used to look like this, and then they developed this consolidation. So I'd say most people, especially residents, would say this is pneumonia, and they could be right. Usually they are. But the other thing to think of whenever you're thinking of it, you see a patient with interstitial lung disease, is could it be some sort of exacerbation of their underlying autoimmune cause resulting in pneumonitis, because the treatment's different, right? So if you have UIP or some sort of autoimmune disease, and there's more of a pneumonitis from the underlying autoimmune cause, then you might treat it with steroids. You might change their treatment as opposed to treating them with just antibiotics if it was a pneumonia. So important distinction to make. And especially if you're on call, you might be the first one to notice it, because if you don't, it could result in more fibrosis from that episode. All right, any questions on that one? Okay, and then we have one more case. So here's an X-ray. And there's some opacities in the mid to upper lobes. And then here's some CT images. You can see some ground glass opacities. Anybody know what this could be or have any thoughts as to what the diagnosis is here?
hypersensitivity pneumonitis.
Yeah, that's a good suggestion because of all the ground glass, right? It's more upper lobes, the distribution's correct. I would say that there's probably no air trapping. I didn't give you enough images like with expiratory imaging to show you if there's air trapping or not. But just for the sake of this case, I would say that there is no air trapping. You just see ground glass opacities in the upper lobes. So unlikely to be hypersensitivity pneumonitis. So other things to think of would be an infection, right? Now with our patients, and this may not be for you all, we have a lot of drug users, and now this doesn't have that peripheral distribution that we see with septic emboli, but it does have that upper lobe distribution that could be seen with more inhalational disease processes or insults or things that cause damage to the lungs. So this patient had cracked lung, so they were inhaling drugs, crack cocaine, and it caused this lung injury that was more upper lobe because it was inhaled. We could also see this with some types of like if you had an inhalational injury from like burn victims might have more upper lobe ground glass opacities because the lungs are being injured and causes a lot of inflammation, dysregulation of fluid, and so you get a lot of capillary leak and fluid going into the lung tissue, resulting in this pattern. So some things to think of besides some of those that we talked about, and then the more common stuff like infection, especially if it's pertinent to your patients that you have, think about drug use, or maybe they had some sort of noxious gas inhalational injury that resulted in this pattern. All right, any questions? All right, so that was my last case. It looks like we're done with the hour, completed just in time.
Saga, thank you. Hey, thank you so much. So I'm going to close this webinar, and then next month we will have neuroradiology. It's going to be Dr. Xian from Emory University. She was with us last year too. And today that was a great case for the cardiac MRI. I like that case.
I know you would.
Okay. All right. Thank you, Sagar.
All right. Thank you all. Thanks for joining. Bye.
Yes.
Take care.
Okay. Bye.